Hello, I'm Dr. Brian Cole, and I'm going to provide you with a brief overview of the use of MSCs in the treatment of osteoarthritis from the United States perspective. I'd like to thank the On Foundation for agreeing to collaborate in this venture with your society, and I'm honored to take the time to present this to you with this brief overview. Certainly, if you have questions and you'd like to reach out to me, I would make myself available. So, the title of my talk is MSCs in the Management of Osteoarthritis in the American Perspective. I do have disclosures, and these disclosures are through the American Academy of Orthopedic Surgeons website. Currently, the use of orthobiologics in the treatment of osteoarthritis is probably one of the hottest topics that we have to date in orthopedic surgery. Keep in mind we have a number of non-invasive options such as weight loss, activity modification, physical therapy, the use of ice, anti-inflammatories, bracing, and also a number of injections including steroids, hyaluronic acid, and biologics. Now, biologics for the purpose of treating osteoarthritis in a non-surgical sense is probably best for patients who are sort of what we call a tweener, those who are really too far gone for cartilage restoration, such as osteochondral allografts or cell-based technology, and maybe too young for arthroplasty. There is a rigorous regulatory process in the United States. Keep in mind that the types of biologics that we have available to us follow the 361 pathway, which is really the minimally manipulated pathway using these tissues homologously. So said another way, these are basically autologous cells that come from adipose tissues or bone marrow aspirate harvesting with concentration. Could come from autologous blood products like PRP or fibrin glue, and it could be allografts such as amniotic fluid, etc. The main provision is that they are not treated with anything more than minimal manipulation. So simple mechanical preparation is possible, such as centrifugation or resizing, but anything more than that would violate the premise of the 361 pathway through the FDA in the United States. The other premise is that when these are used, they're used at the same surgical setting, and the tissue is basically used in a setting where it potentiates or uses them for the same function, same purpose that they were originally intended in their autologous state. What's not allowed in the United States is cell culturing, where we take cells out of the operating room in the clinic, sorting of cells, adding growth factors or enzymes. Those are things that would put it in what we call the 351 pathway, and essentially those are drugs. So in the United States, cell culturing is not readily available outside of an IDE or a biologics application in the setting of the FDA, and all we have readily available to us in the setting of MSCs is essentially adipose tissue, maybe allogeneic tissue, bone marrow concentrate, and maybe amniotic if they actually have MSCs. The basic premise here is that we have a patient who undergoes injury, who has growth factors that can be present in these various endogenous agents, and that it might go on to repair or reduce symptoms. It's really all about the growth factors. When we're looking at these various substrates to provide growth factors, the aim is really to manipulate the intrinsic growth factors in such a way that we can basically upregulate what's already in the body. It's our intrinsic body's ability to heal. We sort of turn up the good and turn down the bad. So there are anabolic factors and there are catabolic factors, and the hope is that this interplay, especially in the setting of the treatment of osteoarthritis, can be leveraged when we're using various sources of MSCs. And I'm going to get into MSCs a little bit further in terms of how they actually function. So we have lots of optimal goals in the use of biologics in the treatment of osteoarthritis, such as modifying disease. Maybe we can prevent cartilage damage. Maybe it can be used as an adjunct to surgical intervention. But really, we're looking for the non-surgical treatment of osteoarthritis to modify symptoms. Now, there are a lot of biologics that we have available in addition to so-called MSCs or cell-based technologies, such as viscosupplementation or autologous blood products like PRP or fibrin. But the types of cell-based technologies that's the focus of this talk are really bone marrow-derived, adipose-derived, maybe synovial tissue-derived, or peripheral blood-derived. There are some applications for placental tissues such as amniotic or umbilical cord, and then there are those features of isolated growth factors. But to suffice it to say, the things that follow the 361 pathway that we're most commonly using in the United States really fall into the category of bone marrow concentrate and the use of adipose tissue. So what exactly are stem cells? So stem cells, at least by the NIH definition, are unspecialized cells. These are cells that are capable of dividing and renewing themselves for long periods of time, and they give rise to specialized cells. If you look at the ISCT definition, there are several features of this, and that's cells that are cultured, they expand, they actually adhere to tissue culture and plastic. The cells retain the capability of that trilineage differentiation, such as that which can differentiate into bone, cartilage, and adipose tissue. And they also express certain cell surface markers such as CD105, CD73, CD90 with a very high prevalence. They also lack expression of various cell surface markers. So there's examples of this, such as induced cells, embryonic stem cells, these pluripotential cells, as I mentioned, that are induced. But these are not the same things, nor do that we utilize when it comes to bone marrow or adipose, for example. And I think it's important to keep in mind that the take-home is that while stem cells function in a certain way in vitro, the way they function necessarily in our bodies are very different. And I think the very least, and sometimes the very most we can expect, is that we're going to harness the growth factors that are provided from these cells. And again, they can be provided in a variety of ways. It doesn't necessarily have to be MSCs. It can be blood or autologous products as well. Keep in mind also that the one limitation being that we're comparing things that happen in vitro in culture versus what happens in vivo in a disease state. We're also dealing with when stem cells are present, they are present in very low concentrations. When these cells are present, we sort of have shifted away from the paradigm and we consider them what Arnie Kaplan has popularized as sort of medicinal cells, sort of little pharmaceutical warehouses, if you will, that can recruit other stem cells. They can secrete bioactive factors such as cytokines and chemokines. Then they can modulate the inflammatory response and even immunomodulate T cell surveillance. So they may have important roles, but I think it's important to keep in mind that they're not necessarily being harnessed for the regenerative, restorative, or disease-modifying capabilities at this time. So we commonly get these cells from bone marrow and from adipose. Those are the two most common ways that we currently do this in the United States. When it comes to bone marrow-derived cells, we use a bone marrow aspirate concentrate that can be harvested from the iliac crest, the proximal tibia, the proximal humerus, the distal femur, even the proximal tibia. And they're essentially centrifuged for a period of time to take advantage of the specific gravity of mononuclear cells such as MSCs. There are some cons because there is some donor site morbidity. It can be uncomfortable in the office setting, and there is a cost to the procedure that's not reimbursed typically by insurance. So this is a case example of a patient who has a focal defect of the patella and basically showing debridement. And at the end of the case, this is a high-level athlete. We had harvested bone marrow aspirate from the iliac crest and we injected them at the end of the case. Now, why? Not necessarily to restore the surface of this patella that we're debriding or restore some of the arthritic changes in the trochlea, but rather to help modify the post-operative process and reduce inflammation, possibly make the patient feel better early in the post-operative period, and maybe provide a more robust clinical outcome by inhibiting the inflammatory milieu that's associated with this cartilage breakdown. There are a number of articles that have looked at this, and there's actually a couple of level 1 studies that have been prospective. I think that the general take-home in the literature when it comes to bone marrow concentrate is that the literature basically shows that it can augment surgery, especially in the area of focal cartilage defects, but lacks convincing evidence in the treatment of osteoarthritis, and it really needs more research. The general take-home from all of these studies is that the populations are often very heterogeneous, difficult to control for, and the most substantive data has been in the treatment of focal cartilage defects using MSCs, especially bone marrow concentrate, to augment the surgical environment. However, we still have a lot to learn as it relates to the need for prospective research with the use of bone marrow concentrate in the setting of osteoarthritis and modifying symptoms. There's also data available with the use of adipose derived stem cells. So this is lipoaspirates taken from the abdomen, the flank of the thigh, that are mechanically processed. Now, the pros are there's no significant decline of cell number as we age, in contrast to bone marrow concentrate. It's pretty easy to harvest with minimal morbidity, but maybe more so than what we get from bone marrow. And it does have a relatively large yield of cells, but there is some morbidity and there is a significant cost, again, not covered by insurance. Similar to the use of bone marrow concentrate, when we turn to the literature, we still have questions related to its efficacy. The literature is very favorable, but some questions remain. What's the optimal harvest site? How much do we need to harvest? How often should we inject? What should we inject specifically? And are our primary outcome measures actually adequate in terms of what we're measuring? So I think much like bone marrow concentrate, we're still in a situation where the use of the liberal use of adipose tissue to treat the symptoms of osteoarthritis may have some benefit, but it still is yet to be determined conclusively. So in summary, the data is suggestive that a reduction in the symptoms from osteoarthritis might occur with the injection of MSC preparations. The use of MSC preparations is not likely regenerative, restorative, or disease modifying, but rather symptom modifying. And I think the most critical aspect from our perspective is that patients must be educated properly to manage their expectations, especially because these treatments are not covered by insurance and are still considered an out-of-pocket expense for our patients in the United States. So thank you for your time, and I welcome any questions that you might have, and you are welcome to email me at bcole@rushortho.com. Thank you.